Hi, Zamir.
Hi Shri Krishna, how are you?
I'm fine, thanks. Just,
How's everything?
just waiting for your talk.
Oh, all right,
Did you
thank you.
did you finish your wax talk already?
No, I haven't done it as yet. I'll probably do it this weekend, I think. Maybe on Friday. I've scheduled it for Friday. I'll just get to my
So
head.
how the rest of the gang doing?
Everybody's okay, I suppose. People are
They
slowly
all
down.
they must be oozing with knowledge all through. Smoke coming out of their ears.
I know we have done so many talks this time. Let me just check what is the number of this talk. I forgot.
What's the scene like in UK now?
UK is now starting to ease off. We are from 1st of June, they're going to restart some schools. They have also decided to restart basic, non-essential shops as well.
Hmm.
15th of June, they're saying they will even make it further lax. The number of daily deaths is going down. We peaked at 1,000 plus deaths a day. Yesterday was 120 deaths, so in a way we are happy. But still, we are 37,000 mortality, which is huge numbers.
We seem to be increasing here because of a
Yeah,
lot of
I,
movement going on, and all these trains
yeah,
and this thing going on. So
I think Narendra,
people are getting restless and impatient, and they're just wanting to get out and get into trouble.
yeah, the problem is, of course, people don't have food to eat. That's the problem. I mean, the issue is India is such a daily wage earners economy. I mean, a lot of people are daily wage earners. So I don't, I don't blame them. I don't blame them. What do you do?
I know. 1.3
No,
billion. What to do?
absolutely, and really, there is no food now for them. I mean, we are getting feedbacks from Bombay, and it is very bad actually.
Bombay is very bad. Yeah, Bombay is
And because I trained and grew up in Bombay, I have my school, medical college group is all in Bombay, so they are discussing all the issues there and in the hospital as well. It's very depressing to listen to all that. It's really depressing.
where did you train in Bombay?
KM, I'm a KM graduate and
Oh,
I'm a postgraduate from Nair Hospital, TN
oh,
Medical. So mine was the first batch where we went for before my batch, you did your undergrad and then you got your postgraduate in the same college and you passed out in the same college. But mine was the first batch where it became the four municipal colleges became together. So I did KEM MBBS and MS from TN Medical, and then I came to the UK straight away. After MS, I immediately came back as soon as my results came.
my
So
MCH was from Kenya.
yeah, I had actually got into MCH in KEM in cardiothoracic surgery, but at the same time I passed my FRCS exam because Bombay University was recognized in those days for FRCS. So I gave my FRCS directly after finishing my MS. So luckily I passed the FRCS. So I came to Magdi in at airfield straight away. I remember sitting almost 4 days outside his office waiting to meet him.
What is FRCPS?
Oh, that's I just changed it today because Glasgow is called as College of Physicians and Surgeons. Shan
Oh,
told me last evening that instead
oh,
of putting FRCS, I should put FRCS. In fact, today is the first time I've ever used that.
okay. It's a combined college, is it? Physician and
Yeah,
surgeon.
Glasgow is FRCPS.
Oh, okay.
I always used to put FRCS, and this is the first time I've actually used that because Sham last evening was talking to me and he said, your degree should be FRCPS rather than FRCS. But actually, my diploma says Fellow of Royal College of Surgeons and Physicians of Class.
Okay.
And then when you pass your exit exam, then it is FRCS CTH. Because we were trying to get the London College of Physicians CME for this program. So because if we are applying for CME, we have to show that we have a affiliation to the college. So that's why
I saw some messages going about CPD. Why you call it CPD?
Yeah, continuing professional development. That's what it's called.
Okay.
Continuing professional development. That's the word used in the UK. So rather than calling it CME, the word is continuing professional development. Because we all have to maintain a portfolio. Because GMC has got revalidation. Right? So every 5 years we have to undergo revalidation. So because we have to undergo revalidation, we have to maintain a portfolio for our practice, and the portfolio has to have CPDs and annual appraisals and everything. It's a very rigid protocol. In fact, I am due for my revalidation 2022. So you have to go through 5 years of appraisal and show career progression, and quite rigorous actually, but it's a good exercise. Maybe one day for the youngsters, I might take another talk on how to maintain a career portfolio, because they really go through some serious stuff in the UK. My revalidation is 2022 or 21. I don't remember. I'll have to look back at it.
You have to do an exam as well?
No, not exams. They haven't as yet introduced the exams, but they do use the basis of your 5 years appraisals over with your peers. So there is an annual appraisal which all of us have to undergo. It is usually with peers, and there is a very rigid protocol for the appraisal. So there's a lot of things that goes into the pathway, and then they look at career progression, this, that. So it's quite a big thing. So Sham appraised me last year. It goes through somebody called as a responsible officer in the hospital.
Sham and me did our MCS together.
Yeah, he told me.
Same time, but I was in KEM. He was in Bombay Hospital. I don't remember.
Is it Bombay Hospital? DK Saxena?
Yeah, he must be.
Saxena was the candidate, no? Was the teacher in Bombay Hospital. So we're almost getting to 5 o'clock. People are slowly starting to log in. There's a slow response today, but that's okay. You're okay with that pulmonary metastatectomy, Sri Krishna?
Yeah, I should be ready by the weekend.
Yeah, take your time and just let me know when we'll do it, and then I'll schedule it.
I could do some interactive sessions with some interesting cases.
Yeah. Tomorrow, if you want, we can do an interactive session. I have scheduled my VATS talk for Friday. So if you want, you can do the interactive session. Do you want me to announce it to the IACs as well, or shall we just do it with this group?
Not tomorrow. We will. I have to sort out a few cases because I just got my computer organized and now it is reading my hard drive. So I have to get all the cases and
stuff. I'll tell you, Sri Krishna, the best thing to do is to buy an Apple, a MacBook Pro. I'm telling you, I have used now for close to 10 years and I've never had an Apple crash on me. Honestly. And at the same time, I also have Microsoft laptops because my medical legal work and everything else also gets happened on the Microsoft laptop. But I'll tell you, the difference between using an Apple computer and a Microsoft computer is like base camp and Mount Everest. It's that different.
Yeah,
Really.
it's like owning a Maruti and a Mercedes. We have to afford it. You see.
No, it's not a matter of affording. It's actually, the point is that this computer has become such an important part of our life that it is. I look at it as an investment in the self. So the amount of time that I save by working on a MacBook, which I struggle with on Microsoft computers, so that I balance it out, and then I say it's worth it. So in fact, over the last few years, every 1.5 years or so, or 2 years, I've been replacing my MacBook with a newer version
My
because the
only
soft.
problem with Mac is that everything is in tuned to their own system.
No,
It's
that's not true.
not
That's I used
universally.
to I used to think that, but that's not true anymore. It's completely compatible with everything else nowadays. Everything is compatible. In fact, on MacBook, you can split your hard drive into two, and you can have a Windows. I had Windows 10 on this MacBook which I'm using, but then it occupies too much space, so I just removed it. You can have a parallel system, and you can have a Windows 10 and an Apple on the same computer. But I took out the Windows 10 because it was just taking away so much space. Okay, I think the time is ready.
Yeah.
We are ready to
Yeah.
talk.
Okay.
So let's start this talk. We've got about 23 participants. Okay, so good evening, ladies and gentlemen. Welcome once again to another session of the Thoracic Gurus. Today, I will be talking to you about a subject which is very, very close to my heart. So forgive me if you find me getting passionate, but it is something that, in my mind, clearly defines me as to who I am and what is my in life. Okay, so it's going to be robotic thoracic surgery, and I'll take you through the whole gamut of robotic thoracic surgery. Try and talk you through what is possible, how it is possible, and why robotic thoracic surgery. So I personally am affiliated with four hospitals which do robotic thoracic surgery. The first one is, of course, Medanta, where I helped set up the robotic program for thoracic surgery. In 2010, actually, we started, or 2011, I don't remember when we bought the robot. And that was the SI system. And then we went on to buy a dual console SI system. And then we've also bought a dual control XI system. And then we've also had an S system. So at Medanta, I've had the opportunity to work through three types of robotic systems, S, SI, and XI. This is Bartholomew.
Please record.
Okay, sorry, I forgot. I've lost my, what do you call it? My thought process. Okay, is it recording? Is it showing recording or no?
Yes, now it's
Guys,
showing.
is it?
Yeah, now it's showing.
It is showing now.
Okay, all right. So yeah. So what I was saying was that I started doing robotics after doing many years of VATS. Medanta was the place where I started the robotic thoracic surgery program. At Medanta, we bought SI system. Then we also bought the S system. And then we bought a dual console SI system. So I had the pleasure of working on all of them. And things seem to have worked in that situation. When I came to London at St. Bartholomew's in 2017 or 16, I think, bought the XI system. So they bought two robots by using the Bart's charity. One was dedicated for thoracic surgery. So it's probably, I think, the only robot around the globe which is dedicated to thoracic surgery. And the other one that they bought was for urology and all other specialties. And then I started working in SciFi. SciFi actually bought a second-hand robotic system from Asian Heart. And so they have the SI system. And also now at Wellington Hospital in London, which is a private hospital, we have the XI system. So there are, so I have over the years had the opportunity to work with almost all systems of robotics, and trust me, they are a very different experience. The platform has changed dramatically, and I still hope that the platform will continue to change dramatically for the future. And I'll talk you through it, and I will see how we can, how the various differences between the platforms are. So whenever I talk about thoracic surgery, whenever I go around the world and I discuss thoracic surgery in cardiothoracic meetings, I get repeatedly told that thoracic surgery is a poor man's disease, particularly in Asia. So when I first took a decision to come back to India in 2010, everybody laughed at me. They said, there is no hope in hell. You're running a very successful VATS program in the UK. Why would you go back to India? Because India is all tuberculosis, empyema, this, that. And everybody laughed at me and said that there is no way that you will ever be able to start a robotic surgery, a minimally invasive robotic surgery in India, because thoracic surgery is a poor man's disease. Everything is all like this, dirty, infected, pus, and stuff like that. And the cardiac surgeons would sit on their high horse and would laugh at me, and they would say that we all do posh surgeries, clean surgeries, sternotomies. We don't want any infected cases in our ICUs, in our wards. And this has been the domain, this has been the thought process over many, many years. By the way, these are my two children. Of course, they're grown up now, but these are my two children when I took their picture many, many years. So this image has always survived of thoracic surgery. Thoracic surgery is an old battered car, and cardiac is all clean. But then with the onset of minimally invasive surgery, and with the onset of VATS, uniportal VATS, and robotics and uniportal robotics, the image is slowly changing. And because of this image, I think a lot more people are now getting enamored towards taking up thoracic surgery as a career. And I think technology has had a huge role to play in the change of the image. As I say this, I've said this many times in my lecture in the past, that whenever we talk about thoracic surgery, the image that comes up at the top of the mind is this large cut on the chest wall, cutting through muscles, cutting through fat, and then spreading the ribs apart for 4 or 5 hours, and then getting into the chest and doing whatever surgery you want to do. Sri Krishna and I have both trained through an era of thoracotomy and sternotomy, where these were the main tools of access to the chest. About 15 or 20 years ago, probably, I was fortunate enough to start working with Khalid Emer, and Khalid Emer and I had a different thought process. We started looking at the possibility of doing things by minimally invasive. So when we started off, we did 3 cuts on the chest wall. Here is 1 cut for the camera, 1 cut for the posterior port, and 1 cut for the anterior port. And we found that putting in these 3 ports and putting in a camera, we were able to do almost 99% of surgeries that were possible by open thoracotomy. So gradually our experience increased and we stopped doing open surgeries. There are some cases where, of course, open is still the choice. And even today, I still maintain that the gold standard in thoracic surgery is still open surgery. But majority of the patients don't need open surgery. You can do almost everything in the mediastinum, in the lung, in the trachea, in the diaphragm by putting in a camera. The advantage of this was, of course, that you take away the retractor and you take away the cutting of the muscles, because when we make this incision, we do not cut the muscles. We actually split the muscles, and you use a wound protector, and that just spreads everything apart and you can get into the chest. So gradually with time, as surgeons, we moved on from 3 ports to 2 ports. D'Amico spoke, was the first guy in the US who started talking about taking away the third port and putting in just 2 ports. And then Diego Gonzalez Ribas and Calvin Nug and Alan Seho from Hong Kong, they all took up the mantle of uniportal VATs. In fact, Diego, I think that era was 1998 when we all went on this journey of uniportal VATs. And my first paper in uniportal VATs has been published in 1998, a case series of 65 or 70 cases with uniportal VATs. But come 2001, we diverged in our pathways, and Diego went down the uniportal route and I went down the robotic route. And then when you go down the robotic route, it doesn't make sense to do things uniportal. You actually go multiportal using the robot as a tool. And then from there on, we pushed on to the robotic platform. So the robotic platform was really an amazing platform, which completely changed my life and completely changed my thought process over how to do these surgeries. And so today, I will take you through my journey of the robotic platform. I'll try to share with you the experience of why I do robotic surgery and how I do robotic surgery. These are the 2 questions which I will answer. So, but the important thing is I am not biased against any one of them. I think minimally invasive thoracic surgery should be treated as a armamentarium of tools. You know, when your enemy is common, your enemy is the cancer which is there inside the chest, in the lung. How you access the chest wall doesn't really matter. It completely depends upon your level of comfort in whatever technique you have. And you have the whole tool of techniques, including multi-port VATs, uniport VATs, robotic VATs. You know, robotics for me is just a tool. And I want to say this right at the start of the whole discussion. I do not want anybody to go away thinking that the robotic is the be all and end all of all surgery. What really matters is what you do inside the chest. And as long as you can do the whole operation successfully and follow all the oncological principles that are needed for doing the operation, then the access to the chest wall is not important. Hence, I still maintain that the gold standard with the most experience in the world is open surgery. And then use multiport, uniport, or robotics as a tool to improve your outcomes for the patients. And that is the key message I want you to take it home. I want you to take home. So it is horses for courses. Okay, you must very clearly define, most importantly, what is the disease pathology in the patient. Number 2, how will you get radical clearance of that disease? And third and most important thing, and it is the third thing, is what is your level of skills to choose the tool. So, you know, if you put uniportal in my hand, that is not a good tool for me because my experience is with multiport and robotics. That's why I tell everybody on this program that don't get hooked on to one technique. Early in your training era, you must go through all of them. You must learn every single one of them and then decide what is your zone which gives you maximum comfort. And then you go down that route and do whatever surgery that you want to do. So the question that comes to all of us, and we are asked many, many times in hundreds of conferences by senior surgeons, is why should I change? I have been doing this for 30 years and I'm very happy with it. And I'm getting great results, and why should I change? So the reality is, what's wrong with this? Nothing wrong with this. Absolutely nothing wrong with this. You can still have this in your house and you can call London, Paris, New York, Tokyo. There is nothing wrong with this. But hand on your heart, if you put your hand into your pocket, you're going to come up with this. Okay. So why did you change? Why did you adapt to technology? The reason you adapted to technology is because technology made your life easier. Technology has shown that the outcomes in patients is better when you use certain minimally invasive tools. It has shown that there is less pain. It has shown that there is a better cosmesis. It has shown that there is quicker release, discharge from hospital. So a lot of things come into the picture once you start using technology and become familiar with, and then you start realizing the advantages of technology. So each one of us has to take our own decision as to what is the level of change that we are willing to accept in our clinical practice. So let's look at why robotics. Okay, what are the advantages of robotic surgery? So the first and foremost thing with robotic surgery is the vision. The vision, because the main reason why minimally invasive surgery became so popular is because vision started to get better. Not that we got better as surgeons. The technology got made the vision much more easier. You can only do a good surgery if you can see well. So with on the robotic platform, you have the highest definition of vision. Okay, very, very crisp vision. The second thing is the colors that are used in the robotic platform are true colors. Okay, and most important for me is every single robotic operation can be saved or recorded in the highest definition possible. In fact, some of the systems that we were using for recording on the robotic platform were giving us an output of one file of 20 gigabyte. I'm serious. Some of those files which I have operated on eventually turned out to be a 20 gigabyte file for a 3-hour operation. So that is the level of quality that you can get in the recording if you want to use it. I would not advise you to have such a high level of recording. But many of my files of robotic surgery are actually 18 gigabytes, 20 gigabytes, not because they were very long operations, but they were very high definition recordings. And that really matters. And I'll tell you later on why that matters. Particularly when I do my VATS talk, I'll tell you why recording is really important. The second advantage of robotics is that it is not just one camera. The robotics camera is truly a binocular camera, okay, which means that there is a separate camera for the right eye and a separate camera for the left eye. And the two cameras are fused into each other. And the image is being captured and transferred to the console where my right eye is getting one image and my left eye is getting another image. And the two images are then fused in my brain to create a three-dimensional vision. And so the three-dimensional vision that you get with robotics is a true three-dimensional vision, which means that the depth of perception of the robotic platform is highly, highly accurate. If a structure lies at 1.28 millimeters, it truly lies at 1.28 millimeters. When your brain perceives the depth of vision, it is a very accurate depth of vision, quite unlike the 3D movie that you see in a cinema. When you see a 3D movie in a cinema and you see the T-Rex coming towards you, that is not truly coming towards you. As opposed to that, the robotic platform, if a nerve or a vessel lies at 1.8 millimeter depth, it truly lies. So when your hand moves 1.8 millimeters, the conversion of your hand movement to the instrument is highly, highly accurate. Hence, your surgery becomes very, very accurate and very, very precise. And that's the most important thing about robotic surgery. This technology of getting 3D vision is what makes robotics so wonderful. I have used 3D cameras on other systems. I've used it in VATS. I've used it in in smart ORs and everything. I've tried all the 3D systems that are available out here. I've used it in virtual reality screens as well. But in all of them, my experience has been that the vision that you get on the robotic platform is the most accurate depth of perception. And that is why I feel very comfortable doing robotic surgery. It's the depth of vision is very accurate. The next advantage of robotic surgery is the true dexterity that you get with your robotic camera. So whenever I am using a robotic surgery, whenever I'm using a VATS platform, or I'm doing open surgery, my wrist is restricted by this movement. I can't go beyond this. My wrist is just can only flex this much, can only extend this much. The robotic surgical instruments have an endorist, which has got nearly 360 degrees of rotation. So you can rotate the endorist 360 degrees around. And more importantly, it has additional 7-degree freedom of movement. So check this movement. So this 7-degree freedom of movement plus add the 360 degree of rotation gives you a phenomenal access to any structure. So you can actually swing the robotic instrument from below and look at a structure from below up and start operating with equal accuracy. And that is the important thing to remember. So it really, this dexterity of the surgical instruments makes the technicality of the surgery much, much more precise as compared to any other platform, including open surgery. So to get into difficult areas, to get into tight spaces, to get into narrow areas is an absolute pleasure with robotics, particularly when you're operating in deep cavities. That's why pelvic surgery works beautifully with the robotic platform, because you stand at a distance and you go right into the depths of the pelvis, and your instrument can rotate around in that narrow space, and you can get good movement around very important structures. That is why the mediastinum is a beautiful area for use of the robotics, because in the mediastinum you're around major vessels, aorta, pulmonary artery, you name it, and then from there you can swing into the neck and get into the base of the neck and dissect around major neurovascular bundles. And so robotic works very well in these areas where you're operating from a distance at a structure which is far away from you. And the gamut of instruments available on the robotic platform are multiple. So everything that you can think of now is there on the robotic platform. The only problem is that every time you dock a new instrument, the cost goes tangentially up. Because the problem is that the robotics so far has been dominated by a single company. And what it has done is it has introduced a software in the system where they have locked the use of the instrument to 10 uses. So though the instrument may be good, but once the 10th use is docked into the arm, it locks away the instrument and you cannot reuse it for the 11th use. So the cost of the surgery goes up because more number of instruments that you use, each instrument will add more cost to the operation. So for example, one of these instruments, if you buy, will cost somewhere around 1.8 lakhs, which is around 1800 euros. And then you have to divide it by 10 uses over 10 patients. And so for every time that you dock in an instrument, it's about from 18,000 to 30,000 extra per instrument. So unfortunately, the company has put in the system of locking the instruments, and that has added to cost of the robotics. If these instruments could be used for a longer time, maybe the cost may go down. Okay. The other big advantage of robotic surgery is that sitting on the console, you need very little assistance, very little assistance. Most of the times when I'm doing VATS, I can only control my right hand and my left hand. But when I'm sitting on the robot, I control 4 hands all at the same time. You can control each and every one of those procedures at the same time. And anybody who does VATS will know that the main limitation of doing a good quality VATS is your assistant. Because if your assistant doesn't know how to hold a camera, your life is hell. Your life is absolute hell with the camera. As compared to that, on the robotic platform, you control the camera. So you can move the camera forward, you can move the camera back, and it's a very stationary platform. So you are in control of what you want to see. And so you don't have to depend on an assistant. So that is the real key for robotic surgery, that you as a surgeon control everything at the of the equipment. But you still need a very good assistant at the table for 2 reasons. Number one is, of course, the assistant changes the instruments for you as you want. Or if you're doing a hybrid robotic assisted VATS, then he will use a stapler. through the port for you. So while you are doing a VATS robotic dissection, the assistant will be doing what is essentially a VATS stapling of the blood vessels or the bronchus. If I'm operating in London, then I will use my robotic staplers. But in a country like India, the cost of robotic staplers is too expensive. Hence, we try to use the local laparoscopic staplers. So that's one. And number two, the reason why you need a very trained assistant at the bedside of the patient is because if something goes wrong, or if you have a bleeding, you do not have the time to change and come back into the operating theater because you are not scrubbed. You're sitting on a console unscrubbed. So that is why you need a very trained guy at the table so that if something goes wrong, he takes control and he can just either open the chest or take over by VATS and apply pressure by the time you get up from there and you put on your gown and things like that. So don't think that the assistant is not important. Actually, the assistant is more important in robotics because you rely on the assistant to save the patient's life. But during the course of the operation, you don't need the assistant's help. So in my surgeries, most of the times the assistant will be just sitting on a stool and chatting with the nurse for most part of the surgery. So there are many, many instruments that are available on the robotic platform, and these numbers are increasing. And we also have specialized pediatric instruments, which are smaller in size, so they can go down to almost 3 millimeters at the tip. So there are various instruments available for you. The robotic stapler is a fantastic tool, which is designed only for the robot. You cannot use it anywhere else. And it's a curved tip stapler, which can be, which has the dexterity. Can you see that there is an endo wrist, and it has a dexterity at the wrist, which can move the stapler in any direction. And the firing is done by the console. So you control the console and you do what is called as a controlled firing. The assistant does not fire the stapler as is done in VATS. Again, the further extension of instruments on the robotic platform are the development of vessel sealants and harmonics as well. So all of these technology, everything that is available on the VATS platform is now essentially available on the robotic platform. The only problem is it is very expensive. Every single instrument that you use adds a great amount of cost to the operation. But of course, it adds value to your operation. So continuing on with the advantages of robotic surgery, I think the one big advantage which I find is with dual console. And my juniors will vouch for this, because with a dual console, I am 10 times more comfortable teaching a surgery to my junior most surgeon. Because if you look at the foot here, I also have the same controls as my assistant has. And so when he is operating, I can give the control of some instruments to him. He will start dissecting, he will start doing some things. And if I feel that he's making a wrong move, or if I'm not comfortable with his skills, all I have to do is take over the control, and then I can navigate him through the difficult part and then give back the control. So this is like teaching somebody on a car where the brakes and pedals are with both the driver and the instructor. And that is why I find teaching robotic surgery is 10 times easier for me than teaching VATS. And I mean, in my own group, I have had my first year resident actually doing work on the robotic platform. And I've had young surgeons doing thymectomies with me on the robotic surgery platform. I mean, and it really gives me great comfort to be able to teach. The other advantage of robotics is it makes me a better surgeon. I'll tell you why, because I've got diathermy and dissection in both my hands. And many, many a times I have actually continued doing an operation left-handed. You cannot do that in VATS, and you cannot do that in open surgery. You cannot suture with your left hand, and you cannot use diathermy around the aorta with your left hand. On the robotic platform, it is so accurate and so much you feel the control that I've in fact published a paper on this. a right-handed surgeon doing a left-handed mediastinal tumor resection. Because sometimes the tumors are so positioned that your right hand may get blocked just by retracting. You may not be able to swing your right hand around. So your left hand can come into play and you can do the whole surgery using your left hand. So the robotics platform has allowed me to become ambidextrous, and that is a huge advantage for me when I'm doing surgeries, particularly in the mediastinum. The platform has an inherent ability to filter all tremors. So no matter what you're doing on the console, if your hands are shaking or whatever, that tremor is filtered out through these arms. So when the instrument at the patient end moves, it is a tremorless movement. So if you've had a bad day, or if you've had a fight with your wife or whatever, or you're really fuming and your hands are shaking, then don't worry. On the robotic platform, you can continue to operate smoothly. And at the patient end, it will be a tremor-free fine dissection. And so your surgical career can increase. Many a times you'll find that surgeons, with time, start to get a little tremor in the hands and things like that. And that may actually be negated by using the robotic platform. And that's a huge advantage for the surgeon. The one thing to remember always is VATS is a mirror image. When we look up on the screen on the VATS, when I want the tip of my instrument to move down, my hand has to move up. So my brain has to learn that I have to operate in a mirror image. If I want the tip of my instrument to move left, my hand outside has to move right. When my hand moves right, the tip of the instrument moves left. And this takes a lot of time. This hand-eye coordination takes a lot of time. That is why VATS takes a longer training curve. As opposed to that, robotic is not intuitive. It is actually a mirror image. Is no mirror image. So because there is no mirror image, when you want to move the tip of the instrument to the right, your hand moves to the right. So when you start operating on the robotic platform, it is exactly as if you are doing a open surgery. So robotics is more like open surgery. So a lot of people ask me, I am an open surgeon. Can I jump to robotics straight away or should I learn VATS? The answer to that is, I am a true example of that, that when I started doing robotics, I was highly trained in VATS. I was doing advanced levels VATS when I started doing robotics. So my problem was that my hand-eye coordination was to a mirror image. And so for me to do robotic surgery, I had to unlearn a lot of techniques and a lot of tactics. Whereas somebody who is doing open surgery very quickly can jump to robotic surgery without even learning VATS, because robotics is intuitive, just like open surgery. In open surgery, you want to move anything, you go to the right, you go to the left. Same thing in robotics. Whereas in VATS, your training is different, so you have to unlearn things. So hence, robotic has better hand-eye coordination. And so I feel, and it's been shown multiple times as well, that the learning curve for robotic surgery is shorter than the learning curve for VATS. That is the most important thing to remember. The other advantage of the robotics, as I told you earlier, is its ability to reach distant areas. So I do my thymectomies on the right, I can go across into the mediastinum, I can open the left pleura and go across into the left side and dissect it off the phrenic. I can start my thymectomy in the left side, I can dissect everything, I can go into the mediastinum, go across into the right side and do that. That ability is just, the further away your camera is, the more you get control over the instruments. And that's something you learn when you start doing a lot of robotics, is that the further away you are, the more safer it is to reach a distant area. And of course, the fine dissection gives you safe dissection around vascular structures, and particularly in the pelvis, where the genital nerves are present. Robotics is second to none in preserving the genital nerves and in preserving the erectile function for the patient. In the chest is the phrenic nerve that you can really save well with robotics. In the pelvis It is really the genital nerves which come into picture. So robotics has great advantage there. The newer systems in robotics have the ability of actually uploading the CT scan images into the robotic system. So doing what is called as image overlay guided surgery. So you can actually recreate the anatomy one day before. You can do a dummy surgery if you want and practice your surgery before you go on next day to do an actual surgery on the patient. These all technologies are now coming into the picture with artificial intelligence and with virtual reality surgery. So these are all the new technologies that will actually make robotic even more exciting for new people to learn. Now, of course, anything that has advantages has disadvantages. It would be foolish to say that there is no disadvantage of robotic surgery. The first and foremost disadvantage is the initial higher cost. It is extremely expensive to set up a robotic program. I mean, in India now with the new robots, the cost of the robot can be anywhere between 12 to 20 crores, depending upon what deal you do with the country. In the UK, the cost could be anywhere between 1 million to 2.5 million. So we at Bars did a deal for 2 robots with some disposables, etc., for around 2 to 2.5 million pounds. So it's a very, very expensive cost to invest in a robotic platform. And most importantly, it's not just the initial cost, there is a maintenance cost with the company. Every year we have a maintenance cost of over 100,000 pounds to keep the robot in good condition. And of course, the cost of the disposables is very high. When you start doing a robotic program, the operative time goes up because it does take a lot of time for you to get used to the various technologies that are there within the system. And robotics is not a one-person game. The increased operative time is because it's not just your comfort with the robot, but it is also the comfort of your assistants, is the comfort of the scrub nurse, is the comfort of the circulatory nurse. So the whole team has to train, and it takes a long time when you start off doing robotic surgery. I mean, a straightforward lobectomy, if you open and close, you would do it in 1.5 hours. And when you start your first robotic surgery, lobectomy, you might end up doing anywhere between 4 to 5 hours. So it does have early increased operative time, and it does take time. Initially, when we started the program, for us to even dock the robot, took us 45 minutes to 50 minutes. And that is the time it takes for you to get used to the whole system. But now our docking times are down to 1 minute, 1 minute, 30 seconds. So it really changes with the learning curve. So there is a definitive learning curve. The ability to pull and push vital structures in the mediastinum, it's a different kind of feel. You cannot explain it till you do it. That when you're not sitting next to the patient, and you're on a console, that sensation of how much pressure to give, how much to pull, how much to push is a difficult concept, and it takes time to learn. And most important for me, the biggest disadvantage, which I just said, is the loss of tactile feedback. Even when we do VATS, we are still next to the patient, and we can feel the tissue. We can feel the dissecting planes. And that really matters when you're doing surgery. But when you come onto the robotic platform, the tactile feedback is completely lost. And so you have to develop a sense of feel when you're doing robotic surgery, when you're dissecting. You do not get the sense of this is a hard structure, this is a soft structure, this is a delicate structure. So it's very important to be careful about that. Now, on the robotic platform, they've come up with a new software which actually gives you haptic feedback. So there is a feel of pull and push. So this takes away some of the disadvantage of the loss of tactile feedback, but still it's not the same as open or VATS. And that is why, it does take time to get used to doing robotic surgery. The other big disadvantage of robotic surgery is you need a competent surgeon at the OR. If things go wrong, then you really need somebody to be there at the table to open the chest. And many, many times I have cancelled my case if my colleague or if my assistant is not there or he's on leave. I have not scheduled a robotic case. I will never schedule a robotic case with a new assistant. I need my same team. I need the same scrub nurses. So the team is very specialized for robotic surgery. And so you need to have all of them available in theater whenever you do a robotic case. And the other most important thing is urgent conversion. If there's bleeding, if there's tension pneumothorax, you really need to be able to convert into an open surgery. And so this practice we do every few months in the UK or anywhere in the world. We are supposed to actually practice the drill of undocking a robot. It is a different technique, and everybody needs to be certified in the technique of undocking a robot in an emergency. And you can undock in less than few seconds if everybody knows what to do. If you don't undock the robot properly, you will end up with a dead patient. And so it's a very, very, very important skill that anybody who does robotics, docking is okay, but undocking is the most important thing, because whenever you're doing an urgent undocking, it means you're doing it to save life. And unfortunately, a bleed in the chest can bleed 5 liters a minute. So you don't have much time to get the robot out of the way, because it's very cumbersome. It goes around the patient. So access to the patient becomes difficult when the robot is there. So in an emergency, you really need to learn how to undock a robot. And that is most important. Now, in the third world, everybody asks me this question: how the hell can we start robotic surgery? How the hell do we make it cost effective? Is it possible? So the key to robotic surgery is volume. Whenever you buy a robot in any program, in any hospital, the one thing that you have to focus on is volume. And the way to focus on volume is to drive the robot hard. Now, the one reason why all the airlines in this COVID-19 era are becoming bankrupt is because their planes are sitting at airports. If planes are sitting at airport and they are not flying, they are loss makers. You cannot run a business where planes sit on the airport. The same thing runs with a robot. If you have bought a robot, you have to run the robot hard. You must increase the volume through the robot. So at Medanta, we have a Monday to Saturday, 8 a.m. to 8 p.m. philosophy. You post a patient for robotic surgery, no matter what time, we will get the theater. So the theaters are run to capacity by making it multi-speciality. The key thing is multi-speciality, because if you get urology, gynecology, ENT, and thoracic together, that is the time when you can actually run a robotic platform 8 a.m. to 8 p.m., particularly in the corporate setup. So it's very, very, very important to run the whole program as a multi-specialty. In parts, it's a real, because it's an NHS system, it's a different thing. There is less pressure on you in terms of the accounting and costing. But even now, the pressure is there on them to run the volume. You have to do a lot of volume to keep a robot cost effective. And of course, if you're a big hospital and you have a good buying power and you have more numbers, then you can push the company for corporate and hospital subsidies. So we run, whenever we buy robots and all, we run a lot of bargaining and negotiations to push for subsidies. In fact, if you look in one of my degrees of education, I did an MBA over 3 years. And the reason why I did an MBA was to actually understand when I moved into the corporate world and I started dealing with managers and things like that, I understood that you have to talk the same language as the managers talk. So today, they cannot bullshit me with stupid graphs and, with some ratios and this and that, because I know the language of business and I can talk with them. So you really need to be, if you are a program director of a robotic program, you also have to become like a business leader for that program. And you have to understand how to get corporate subsidies, how to run the business of running a robotic program. And doctors, unfortunately, very few of them know how to do this. The other way is you can buy refurbished robots. So a lot of institutes around the world are now buying the XI system. And because they're buying an XI system, the company does a program of buyback. So if you have an SI system, which was the previous system, the company will buy back the SI and give you the XI at a subsidized price. And then the company will sell the SI to other smaller units around the world or around the country. And so the initial cost of buying the robot goes down quite dramatically. So there are a lot of centers in India who have bought refurbished robots, either from India or from other places. And they're doing equally good job. There's nothing wrong with using an SI system. I mean, the classic example is Saifi Hospital, where Kamran Khan and Imran Hamzawala have run the program so beautifully with a refurbished robot that they have done over 500-600 cases in the first year or two, and really made the program extremely successful. Of course, you can look for donors who will donate towards buying the cost. The important thing is for robotic program is the specialty. The manpower has to be dedicated multi-specialty manpower. So the same nurse can do a urology case and the same nurse can do a thoracic case. So we train the nurses in such a way that they become multi-specialty trained, and that reduces the cost of manpower. And of course, you have to run the low-cost maintenance deals with the company. In India, particularly, I don't use the fourth arm of the robot because the fourth arm is usually used for retraction or pulling, and I don't need a robotic instrument to retract. I have an assistant at the table who is sitting there doing nothing. So I usually get Nikhil or Bhushan to retract for me. So I don't use the fourth arm. So I reduce the cost of the operation. I suture a lot with robotics, as in open surgery. So when you suture a lot, small vessels and things, you can tie off as you do in open surgery. So you reduce the cost of staplers. So you keep the staplers only for the major vessels, and the smaller ones and smaller structures you do with suturing, and that directly reduces the cost of the operation for you. And I take out all my specimens in the third world countries where I work. I take out all my specimens in local urine bag. I take a urine bag, I just cut it across, fold it over at the rim, and I just put a purse string at the rim and push the urine bag in and put the specimen in. That way, you save money on small things, and it all adds up when the final picture is put to you. So these are the techniques that you use to make robotic cost effective. I also drive an ERAS program very strongly. The moment I am on the minimally invasive program, I want my patients to get admitted not the day before. I want my patients to get admitted on the morning of the surgery. So one day's admission is gone. I give them pre-operative, post-operative yoga, physiotherapy, everything. Get them really fit. I use topaz suction drains in almost all my patients, and I push for an early drain removal. So next morning on my ward round, I want the drain to come out if there is no air leak and the chest X-ray shows adequate lung expansion. So the ERAs combined with a robotic platform makes it more cost effective for the hospital. I reduce all my disposable as much as possible. I will use the theater times very efficiently. I try not to use necklines, no urinary catheters unless the patient has had any other morbid conditions. But in all patients, as a routine, we don't use urinary catheters. Most of the patients are extubated. In fact, 99.9% of the patients are extubated on table, and we do not take them to ICU. So we just put them in a recovery room for 4 hours. And once they are fit enough, we send them back up to the ward. And we take great care of pain control. So we start very early transdermal patches and things so that they are not on intravenous analgesics. So we push very aggressively with all of these. So it's a combined technique which actually helps you to reduce the patient's post-operative stay. And if there is air leak, I will quickly convert it into a flutter valve. In day 2 or so, I will convert into a flutter valve. And that way the patient is mobilized and he will go and get discharged. At Medanta, we have local hotels around, which actually serve as a hospital service. So patient doesn't need to be in hospital for a flutter bag. You know, he can go to his hotel room and sit there. And the hospital is a very expensive hotel because every day it costs the patient 10,000, 15,000 rupees, whereas a local hotel will cost you 1,000, 1,500 rupees. So you really don't need the patient in hospital. So we drive the whole program hard. And the way we do it is we understand what is called as day zero bed usage. Okay, with the robotic program, it's very important to understand day zero bed usage. And what does that mean? That means you use minimally invasive, you use ERAS, you do early discharge, and then you reuse the bed for another surgery. The hospital makes the most income when a patient is operated on day zero. There is most expense and most income on day zero. So when you manage to reuse the same bed, you've got limited beds for your specialty. If one patient is lying on that bed for 8 days, that's no good to the hospital. You're losing income the moment the patient lies beyond 2 days on that bed. So we do an ERAS, we get the patient up and about, we mobilize the patient and get him discharged so that another patient can be admitted. So in that way, we increased our day zero from 106 days to 128 days. So that many new cases could be done because of minimally invasive surgery. And so we showed directly to the management that we are able to do more cases of surgery because we are doing minimally invasive. And also because the word goes out that you're doing minimally invasive robotics or VADs, the referrals start to come in, and more importantly, the cross referrals from other specialty in your hospital start to come in. So your numbers go up. And moment your numbers go up, that is when you tell the management, I want to buy a second robot. I can show you that I'm making more money for the hospital by a robotic program, and so on and so forth. And then you buy a third robot. We don't charge extra for doing it by robotics. The main extra cost for robotics is the cost of disposables. Okay, so we try to keep the surgeon fee more or less the same as we do it by VATS or by robotic. So patients can afford the whole thing. But of course, you can also, it is within your ability to work the fee according to the paying capacity of the patient. So some patients may be very poor and you offset the cost. And some patients may be very rich and they can afford your extra cost. So that way, you allow the hospital and the staff to have a leeway to make it affordable for patients. And there's a lot of papers out there which have looked at cost of robotic surgery. And one of the best papers is Raja Flores and Bernard Parks, which have published a comparison of robotic versus VATS versus thoracotomy. And the real outcome of all of these studies is as follows. Let me just go back to this slide. I'll come to the outcome of the studies in a minute. So the cost is because they're a single supplier, there is high capital cost, there's a maintenance cost, and disposables are very expensive. So the real outcome, what we found in these papers is that when you compare minimally invasive to thoracotomy, the hospital stay dramatically goes down with the robotics. The ICU stay with robotics or VATS dramatically goes down as compared to thoracotomy. The need for a high dependency unit. HDU is a system in the UK where instead of sending patient directly to the ward, you can downstage from ICU to HDU to the ward. So need for HDU, high dependency unit, goes down. There is earlier removal of chest drain in the minimally invasive group, and there is less use of analgesics in the minimally invasive group. The factors that were not considered in the analysis of these papers was faster recovery, earlier return to work, the less postoperative complications that are there in these patients, the less need for district nurses to visit these patients, and the less need for rehabilitation. All of these are benefits of robotics and VATS over open surgery. So the final analysis showed that VATS was cheaper than open thoracotomy. The second outcome was that VATS is cheaper than robotics, of course, because robotic disposable is more expensive. But the most important outcome of this was the third outcome, which said robotics is cheaper than open surgery. And this is the key message that you've got to get it across, that robotics actually in the overall analysis of cost factors shows that robotics turns out to be cheaper than open thoracotomy if you take all elements of hospital economics into play. there is, of course, the added element of litigation cost with robotics, which you have to keep into mind whenever you start a robotic program, because it is a new program. There are cases, there are issues with malfunctioning of the robot or harm to the patient because of the robot. So any institution which starts a robotic program has to keep these this sort of issue, the litigation cost, into the picture. Okay. So is it clear so far? Before I get into the clinical side of things, I've got into the management side of things. Is it okay? Everybody all right, or bored shit, or what? Hello? No answer. Anybody wants to respond? Can you hear me or you can't hear me?
It is okay, sir.
Yeah?
Zamir,
Yes,
Can you hear?
Yes, sir. Yes, sir.
Zamir, do you have a standard operating this thing for undocking?
Yeah. I do. I have.
Are you going to be discussing that, or?
Yeah, I can discuss it. It's I have a standard undocking protocol. I have not put it in these slides, but I can share it with everybody. I do have I have an undocking platform. It is legal requirement actually. In the UK, it's a legal requirement for undocking the robot. You have to have a standard operating protocol. So we have an SOP for undocking. I can put it in the slides if you want. Okay, so let's now get on to the clinical side of things. I started with all this management side because it is important to understand why you do robot and how to make a robot cost effective. Now let's look at the clinical side and see how we can work. So the anesthetist is extremely important in the robotic program, and you cannot do it without your regular anesthetist. Very important. Okay. So in my robotic theater, I will always have two anesthetists, for the simple reason that whenever I am operating on the chest, the robot comes in from the head end. So because the robot comes in from the head end, the anesthetic equipment cannot be at the head end. So all the anesthetic equipment is moved to the foot end of the patient. So you need to have extra long ventilator tubings, extra long lines. Everything has to go to the foot end. So in my robotic theater, always I will have two anesthetists, because one anesthetist will be at the foot end, and the second anesthetist, who's usually the senior anesthetist, will come around if anything's going wrong with the tube or needs manipulation or adjustment. So I will always make sure that there are two anesthetists, two qualified anesthetists in theater. The second important thing is I will always make sure that the surgeon is present in the OT prior to induction. So right at the start of the operation, you have to decide, how am I going to get the robot in? How am I going to position the patient? Where is the trolley going to be? All of this is discussed. But now, of course, it has become second nature to us because everybody knows what to do. But when you start a program, it is extremely important that you have to be there in theater for even before induction to direct the whole thing. You are like the director of a big movie set, and you have to arrange the whole set in such a way that everybody understands what you're doing. So this is how we normally dock. So this is how we normally dock the robotics. I am standing at the back of the patient. Can you guys hear my voice now?
Yes.
So when you're docking a robot, you bring it in from the back. The spine of the robot is the most important thing, and the spine of the robot must be parallel to the camera. And then you open it up wide. It is absolutely important to open the arms wide so that you prevent a clashing of the arms. This is with the SI system. So you open it up wide, and then you get it in, and each one of these gets locked onto the port. The ports are special ports which have sensors on it. So these ports have a sensor on it. You have to lock it onto this. They will not lock until and unless the alignment is straight. If the alignment is not straight, the port will not lock. And so it's very important that the alignment has to be done. So this was 3 years or 4 years ago that I did this video, and my docking time had gone down from 45 minutes to 2 minutes 42 seconds. Now my docking time is down to 1 minute 30 seconds. So you can really, with practice and with the whole team getting along, you can dock the patient very well. The XI system is a different system. The XI system uses a different protocol when it is docking. It uses a laser beam. So this is, watch this video. On the thing, you can choose whether it's thoracic or cardiac or pelvic. The moment you press it, the system recognizes where you have to go, and then you roll in the machine. So automatically the pivots will raise and get into position. Here are the pivots rotating. This is an XI system, not an SI system. So the arms are getting engaged. Watch the arms getting engaged. And the moment the arms have been engaged, then you're ready to dock. And then you start moving the docking into the, so it's called as deployment of the boom. Once the boom is deployed, then you drive the cart. There is the cart being driven in, and a sterile member is actually directing the non-sterile member. And we say, the room orientation is what is used. And now watch this cross mark. This cross mark is a laser beam, and the laser beam is targeting. So you bring the laser beam in onto the patient. Watch the green laser beam coming in. You get the green laser beam in, and once the green laser beam is in, you target it onto the anatomy where you're going to operate. So you have to tell the machine that I am going to do the pelvis, or I'm going to do the thymus, or whatever. So once you've done that, then you dock the machine in, and it just clicks in. And then each of these arms are docked in. The good thing about the XI system is that the camera can go into any of these arms. In the SI system, the camera has to be in the middle, and the two instruments have to be on the two sides. As opposed to that, the XI system, the camera can come in any of these arms. So you can change the camera around to get a view from the right, to get a view from the left. And the whole technology is so distinct that the arms can come closer together. They are slimmer arms. So the arms can come closer together. And hence, the clashing of the XI system is much less than an SI system. The SI system, you have to put the ports as far away from each other as possible. A minimum of 9 centimeters between the two ports. In the XI, you don't have to worry about that. In the XI, the ports, the distance between the ports can reduce down to 7 centimeters. And so that is a huge advantage of an XI. It definitely gives you a much more closer docking and a much more stable docking. So here is the camera being docked onto it. And then you dock the arms according to the needs of the thing. So once the camera is in, you do what is called as targeting. So you press a clutch button here and the camera is going in. And then once you have done that, you stabilize the patient's body wall and you do the targeting. And the targeting, you have decided if this is a thymus that you're operating, then the whole boom is moving to target that instrument, or to target that organ. So it has an ability of 360-degree movement on the boom to target. So the same setting can zoom around and target the chest. The same setting can turn around and target the pelvis. And that is a big advantage of the XI system. So it's a completely different targeting system. This boom at this top swings 360 degrees, and that is what makes it more accurate in targeting. I promise you, when you start doing robotic surgery, the most difficult part is docking. Once you learn to do the accurate docking, then the whole surgery becomes a piece of cake. It's the docking that needs to be learned. And if you use an XI system, the docking is much easier than an SI system. Once you've done that, then you go and sit on the console, you press the button. It has a preset memory for my last position. It, like a Mercedes-Benz car seat, I can press a button and the whole machine will move up and down to my level of comfort to make sure that I am at the right height. I've got these two things on, I got foot pedals on the right, which are diathermy. I got foot pedals on the left, which are clutch, which can help me get the fourth arm. Here is the 3D vision. So this is the right eye, this is the left eye, separate vision. And then my brain will fuse it to form a thing. I'm sitting there comfortably, my hand is rested, really relaxed. And then you do what is called as a pincer grip. So the pincer grip gives you control over the instrument. And then just by rotating clockwise or anti-clockwise and moving the hand forward and backward, you can actually replicate your whole movement on the robotic platform. And that's the beauty of this surgery. Okay. Did you guys understand docking? Hello?
Yes. Yes.
Okay. So this is the way you dock the robotic platform. Okay. Now, how do you start a robotic program? You always start a robotic program by small fish. Okay. Always look for the small fish in the town. Okay. Look for the really easy ones. And the easy ones in town are small posterior mediastinal tumors, a mediastinal cyst, a pericardial cyst, or a sympathectomy. To be honest, in my opinion, a sympathectomy is definitely an overkill with a robot. I do not really recommend it to a patient. But if somebody insists, then that's a different issue. But it's an easy surgery in terms of learning how to run the robot. Then once you're comfortable with the console, once you're comfortable with how to use the various the settings of the robotic program, then you move up to the next level. And the next level is the intermediate fish. For me, is thymectomy for myasthenia gravis. This is actually an easy operation which can be learned very, very well with the robot. And the robot comes into its own when you're doing thymectomy. I read it's a beautiful operation. Then you can do a small thymoma and suturing with the robot is another magnificent tool. The ability to suture with the robot is just like doing it by open surgery. It's almost as if you're sitting in the chest and you're lifting the structure and putting a suture. So your hand movement is just like this, and tying a knot is you just replicate the knot tying movement of open surgery, and the robot does it for you. So in VATS, suturing is very difficult, technically very challenging. You need to practice a lot for that mirror image to become good at suturing with VATS. And unfortunately, as thoracic surgeons, we don't do enough suturing on the bronchus or on the pulmonary artery, as opposed to the laparoscopic surgeons who suture the bowels all the time. So it is very important. The robot gives you great ability to suture. Hence, for me, eventration of the diaphragm is a beautiful surgery to do by robot, because it allows you to take nice bites of the diaphragm and allows you to tie down the diaphragm and pull the diaphragm down with a perfect knot in place. So it's really, really important that we learn the intermediate operations before we get on to higher operations and try to get the big fish in the market. And the big fish in the market, in my opinion, is lobectomy for lung cancer. It's not an easy operation by a robot, and you really need to know what you're doing before you jump into trying to do a lobectomy for lung cancer. The other thing is, of course, lobectomy for tuberculosis and aspergilloma. I have a lot of experience now in a big collection of TB surgery by the robot. And it really adds value. The robot, in my opinion, adds great value. Where the more complex the surgery, more is the value of using a robot. Resection of large mediastinal cysts and tumors, tumors with spinal extension, and trying to do spinal surgery in addition to robotic lobectomies. Thoracic outlet is just an absolutely beautiful indication for using the robot, because the ability of the robot to lean over the tumor and to dissect the tumor off subclavian artery, subclavian vein, and the brachial plexus is second to none. The flexibility of the instruments, of the robotic instruments at the thoracic outlet is just amazing. VATS does not give you the same access to the thoracic outlet, because remember, the VATS instruments are straight. And when you come at the thoracic outlet, you cannot see beyond the top of that tumor at the thoracic outlet. Whereas the robot can go forward, lean over and look at the top. And so everything can be dissected under vision, and you can bring the whole tumor down very safely. I think sleeve lobectomy is a beautiful example for robotic surgery, because again, the ability to suture with the robot is extremely fantastic. So sleeve lobectomy, a sleeve resection, or the esophagus. Esophagus is just phenomenal. To dissect an esophagus with a robot is beautiful. And there's enough evidence now which is showing that the lymph node dissection with in esophageal cancer with the robot is much higher than VATS or laparoscopic esophagectomy, and even by open esophagectomy. So there is the Chinese and the Japanese have published multiple series. I was recently in some meeting and I heard these guys talking about 400 cases of esophageal esophageal dissections with lymph node dissection, and a comparison of open versus robotic. And they found that the number of lymph nodes that they could get out with the robot was much, much higher. Pneumonectomies, I do my pneumonectomies using the robot, particularly for destroyed lungs. I find the robot is very, very good to dissect all the adhesions of the chest wall, to dissect it off the diaphragm, and to dissect these adhesions of the thoracic outlet. That is where the most problem happens when you're doing a pneumonectomy. Segmentectomies is an excellent surgery, and we are doing a lot of it actually. At BARS, these guys are doing phenomenal amount of segmentectomies. And now the robot has been used for further indications like chest wall tumors and other surgeries. So having just given you a brief outlay of what is possible, let's get into the surgeries and see what is possible. So thymic surgeries, anything and everything on the thymus can be operated by the robot. Something like this, a simple straightforward or a 4 or 5 centimeter thymoma is excellent for taking out by robotic surgery. The larger size thymomas, you can do the dissection with the robotic, but worry about the capsule, breaching the capsule, and also worry about how to get the specimen out. So all of us have done, tumors which are 8 centimeters, 10 centimeters, 12 centimeters. But really the risk of these tumors is being taken by the patient, because if you rupture the capsule, you're making a stage 1 into a stage 4. So you've got to be very careful in making a decision about doing a large tumor by robotics versus open. The more older I'm getting, the wiser I'm getting, the less I'm inclined to use these tools for larger tumors. I think safety of the patient is the most important thing. When I was younger and when I was more aggressive, I would really push hard to do everything by VATS and robotics. But now I'm getting a bit more cautious about large tumors and whether I should really do it by robotics, because I am not doing the patient any favors if I'm going to cause him recurrence in 15 years' time. So very important to get the philosophy right. You should not compromise the surgical principles for access. Access is not the important thing. The surgical principle is the most important thing. So if you've got a tumor like this, don't even think about it, okay? Just go ahead and do an open surgery and take out the tumor safely. The key thing is you don't want to spill the tumor into the chest. I personally do my robotic thymuses from the right side. I have also done it from the left side. There are people who are fanatical about the left-sided approach. They jump up and down all over the podium trying to talk about left-sided approach. It doesn't matter. Whatever is your level of comfort, whatever is your level of thing, as long as you can safely take out everything by the platform, it doesn't matter. I go with the right side because I find there's a lot of space and manipulation is easier. And for younger people, it's easier to go from the right side. But there are proponents who talk about the left side, and it's okay. It doesn't really matter. You can go bilaterally as well. And now I go sometimes sub-xiphoid. So I go sub-xiphoid and I access the thymus from the right, from the left, and dissect it off of the phrenic nerve from either side. I always use carbon dioxide in my robotic surgery because carbon dioxide dissects ahead of me. So whenever I infuse the carbon dioxide, as I'm going in with the robot, one, the camera is always clean, so there is no fogging of the camera. And the second thing is, as I'm dissecting, the CO2 is moving ahead of me and dissecting the plane down for me to open up the people who go from the left side do not open the right pleura. I personally like to open both pleuras widely when I'm doing my robotic thymectomies. I want to see the phrenic nerve on both sides. I want to lean over and see the left side and the right side. And my dissection is always complete phrenic to phrenic, completely clear away all of the pre-pericardial fat, and most importantly, clear away everything in the neck and also the aortopulmonary window. So I will aggressively go into that area and clear away all of these aortopulmonary windows. That's my standard position for thymectomies. Though in the UK, I have a sandbag. And because I have a sandbag, I can move this hand down here. And so this, if you put your hand out here, sometimes the shoulder comes in the way of one of the arms. So in Medanta, I never had the sandbag, so we couldn't push it down. But in the UK, because we use sandbags, you can very easily push it down here. And the arm comes away, the shoulder goes down, and there is no clashing of the instruments. So this is how we do our. This is actually my year 1 or year 2 resident doing a thymectomy. I specifically show this video because of the ease with which the dissection is taking place. Look at the way the resident is very, very neatly dissecting everything off the pericardium, very nicely dissecting the left side, going all the way into the left phrenic. He's going into the neck. And remember, this is a year 1 or year 2 resident who's doing this surgery. So it's a beautiful tool to teach a junior resident to do this. Here is the brachiocephalic. And, I'm suddenly feeling very comfortable. I clip the thymic vein. I don't use the robotic clips because they're very expensive. In UK, I use the robotic clips. And then my resident is very safely delivering the horns in, and he's pushing it all down and nicely clearing the entire aorta, the entire brachiocephalic area. He is going to go, he's taken it off, and then he goes in there into the aortopulmonary window in a second, and he will take out all the fat and pad from there, and then swing it around into the near the diaphragm and take away all of the fat from the pre-pericardial area. So once all this has come out, you will see that it's a completely clean area. There is no fat to be seen. That is the key thing. All fat should be removed. But of course, not at the cost of the phrenic nerve. So you got to be very careful. And around the phrenic nerve, you should not use diathermy. And you should try and do as much blood. And this is the local urine bag, which I use as a specimen. And now the thing is going in there. I think this was Narendra doing the case, and an excellent operation done with everything removed, complete clearance. This is the aortopulmonary window which has got out. It's got all the preperitoneal and got into the neck and done everything completely clearly for this patient. All my patients are extubated on table for thymectomy. The myasthenias may be kept overnight in the ICU if I'm worried about myasthenia crisis. I never ever use epidural catheters, no epidural catheters. All chest drains are removed the next morning, absolutely mandatory. Admission in the morning, surgery scheduled for 2 p.m., topaz suction device, drain removed next morning, mandatory, and discharge the same day or the next day. So my average stay in robotics thymectomy is about 2 days. So that is the important thing that you have to understand. Now, I want to just ask a question. Did everybody see the video, or was it very staggered?
Sorry.
Did the video run smoothly, or did it?
Yes.
Was it
Yes.
very
Smooth.
staggered?
It was good. It was very
Smooth.
See the video, you could understand it well.
Yeah.
Yes, sir. Yes.
Thanks, Sri Krishna. It's just I was worried that the videos may not play very well. Okay, so as I told you, the robotics has to be added on with everything that's available at your disposal to make it smooth for the patient. So in India, because I have a yoga teacher with me in my group, I use his techniques. He comes in pre-operatively, teaches my patients all of these techniques pre-op, and within 3 to 4 hours after they come out into the post-op area, he will come back and quickly mobilize the patient and get him out of bed. And next morning, we have on the 5th floor of Medanta an Ayurveda garden. This is a strategically placed garden where my yoga therapist will take the patient out and get him walking around this garden. There are all these smells and leaves. I don't understand any of this technology, but the patients come back and they feel good. They tell me that they're feeling good, and that is why you feel confident to be able to discharge the patient. If a patient has long-term pain in any of the ports, then my integrative medicine specialist, this is Dr. Geeta Krishnan, and that is Mr. Sharma. They do all these techniques, of Ayurveda for local pain relief, and people are getting fantastic results with these techniques. I don't genuinely understand the science behind it, but the moment you integrate with these local guys, it becomes an international seller. So we have published this extensively, and now Geeta Krishnan, because of his integrated medicine work, is now working in Geneva with WHO, and now the WHO has got involved, and they are looking at using integrative medicine with complex surgeries. So it is you have to use whatever is there at your resources. The one thing is to have an open mind. Keep your minds open. Use everybody's knowledge for the benefit of the patient. And that has been my experience in India, and it has really worked beautifully. Now look at this cosmesis. In the old days, you would have made a big scar in the midline for this young girl, 20, 21 years old. And look at this. Here, one scar is in the axilla and 2 scars are in the breastline. When this thing goes off, she will never even see the scar once they heal. And once she wears a bra, all the scar lines are gone. So it's very, very, very good technique to use once you start doing these surgeries. If you look at the literature and look at evidence-based recommendations, now robotic thymectomy, now minimally invasive thymectomy is starting to come in the evidence. So, early thymomas, stage 1 thymomas are now being recommended to be operated by minimally invasive, either by VATS or robotics. Of course, the higher grade thymomas, they still say you should do it by open surgery. The benefits of robotics in versus VATS are quite a few, and we have spoken about it over the period of time. And now with Jens Ruckert's paper coming out, Jens Ruckert has published a series of 300 plus thymectomies where he's compared clinical results. At the end of the day, what you want to prove is that the surgery that you're doing by robotics is just as good or better than open surgery. And so now Jens has shown a significant benefit in the group with robotic surgery. They are getting better results with the robotic thymectomy as compared to open thymectomy. And not only that, they have got 5-6 years follow-up, and they're looking at remission rates and they're looking at improvement. And they have categorically proved that there is actual benefit to the patient by doing robotic thymectomy. Their symptoms do not regress, and they do not need recurrent surgeries. So this is an excellent paper by Jens Ruckert, which has looked at all aspects of robotic thymectomy and concluded that actually robotic thymectomy is better than VATS thymectomy and open thymectomy in terms of outcomes for thoracic, for myasthenia gravis. So once you've done thymectomies in myasthenia, then other things, mediastinal tumors you come across. This was the last one which we took out. This is the one I was telling you. I took it out left-handed because it was it was placed completely on the left side. My right hand couldn't go to the top. So using my left hand, I dissected the whole tumor out. This is about a 10 centimeter tumor. And surprise, surprise, eventually the histology came back as a carcinoid. So I don't know what the hell it was. In the thoracic outlet, it's beautiful. It's beautiful. I told you the ability to dissect it of the brachiocephalic, of this brachial plexus and of the subclavian artery and vein in the robotic platform is second to none. It's really a great tool in the thoracic outlet. And something like this, such a big, large tumor, see, but we actually went in by robotics and we managed to take the whole thing off from the top and all the way off here. And we didn't even need to do any lung resection in this patient. and the outcomes were acceptable for the patient. Posterior mediastinal tumors are excellent. You really can dissect very nicely of this rib, and something like this will come out. This was a large 18 centimeter tumor which was enveloping the aorta. So it was completely sort of 2/3 surrounding the aorta. And because we had the robotic platform, we actually did a subadventitial dissection. So we actually lifted the tumor and lifted the adventitia of the robot. And because I was so confident about my vision, and I was feeling so confident about my control of the tip of the diathermy, that I could dissect the whole tumor off the aorta completely and then bring it out. It's worked well for the patient. Parathyroid adenomas are increasingly being picked up, and now I have a large series of robotic resection of parathyroid adenomas. All of them have preoperative CT scans, 3D reconstructions, and SPECT scans, depending upon whatever institution you're working with. I personally give preoperative IV methylene blue to these patients at the time of the induction. And once you give this IV methylene blue, it gets selectively picked up by the parathyroid adenoma. The problem is the parathyroid adenoma lies within the fat of the thymus many a times, and it's very difficult to identify where is this parathyroid adenoma. So once you're given methylene blue, look at this bluish hush, and the adenoma is clearly defined, and you can very easily take it all off and do the whole surgery more safely. Of course, I do the levels, parathyroid hormone levels and things like that. This particular case is a disaster which I want to share with you. While I was doing a robotic parathyroidectomy, the parathyroid adenoma was in the same area where station 2 lymph nodes, like a paratracheal area, is there. And here is the IVC, the SVC and the azygos. And I am nicely dissecting. The whole surgery is going beautifully. Very happy with the dissection. Everything is going smoothly. Watch this video for what can go wrong. And very quickly, a very controlled situation can become, completely uncontrolled. So I am taking it off the trachea. This adenoma was within this fat tissue. I knew it because I had seen it with a SPECT scan. And then what I did not anticipate or should have anticipated is the feeding vessel for this adenoma. So everything is going smoothly. I've got the whole tumor out, pretty happy. In a second, you'll see it in a few minutes. I tried to keep some of the normal dissection there. So I'm taking the whole adenoma off. It's deep in the mediastinum now. And there I am taking the adenoma, all the fat in that area, retro SVC. So I've gone behind the SVC. And then I don't realize that actually the feeding vessel for this adenoma is coming from the subclavian artery, which is outside the chest, okay, outside the thoracic outlet. And I am dissecting, and then I get a little bit of ooze. Look at that little bit of ooze. And I'm still in control. It's not as if I've lost control at this stage. And I grasp it, and it seems to have stopped. And I was quite happy. And then I said, okay, just one last Liger clip needed to be put. And the operation was going to be finished. And then the next thing I knew, the whole thing blew into my face. And I had like liters and liters of blood in the chest. And, a relatively simple, straightforward operation ended up with a large thoracotomy and packs and repair of the subclavian artery. Complete disaster. Because what happens is when you lose the feeding vessel, it retracts. And the moment it retracts, you cannot see it from the chest. And so the only way to do this is to then open the whole chest wide and get to beyond because this is retro SVC. So we had to then go in, sloop the SVC, lift it up, and then get into that area and put a vascular clamp and put suturing on. So I called in the cardiac surgeons, and so we had to do an urgent undocking. We did a thoracotomy, we packed the whole area, and we sutured that area. and we lost almost a liter of blood. So that's the difference between robotics and VATS. When you're doing it by VATS, because you're physically there, I could have just applied pressure and I could have got away with it. But the problem with the robot is it's all a closed system. There is no open area for a large swab to go in. And, I was unable to apply pressure with the robotics. And so that is something you have to really understand. And then, of course, you lose time in undocking and then getting in scrub. And so we all lost almost a liter of blood in this patient, and a simple straightforward operation got converted into a major complication. So it is something that you learn and you sort of live. So now we talk about robotic lung resection. So what type of lung resections do we do using the robotic platform? So I do robotic lobectomy for lung cancer. I do a systematic mediastinal nodal dissection. I'm a follower of Khalid Emer's philosophy. So I really aggressively dissect every single lymph node. Again, I have a large series for robotic lobectomy for aspergilloma. This is the most complicated operation that you can come across. I personally feel that this, for me, is the most challenging one, and the robot adds the most benefit for these operations. Again, pneumonectomies, metastatectomy for thymic cancer. So this is my position for a robotic lobectomy. I will break the table, always try to get the intercostal space wide open, always a little booster, because this was a female patient, the hip was wide. So you put in a little booster here to lift up the chest so that your hips don't get in the way. I break the table like this, exactly as I would do for a VATS. My thing is same. And then I will make these incisions 1, 2, and 3. These are my robotic incisions, and this is for my assistant. Always I'll make an extra incision for my assistant. So if I'm using 4 arms, then this is it, camera port. This is my first arm, second arm, and third arm. If I'm using 4 arms, or very often I delete this third instrument arm and I give my assistant an assistant port, which is again a triangulation in the 2 anterior ports. So this is my assistant port, and the assistant will usually get a 12 mm port. So he can put in staplers, he can put in suction, he can put in Liger clips. So very often in India, I do away with this. In the UK, I use only these top 4, and I don't use the assistant port. So it depends on horses for courses. You just choose what is available. So this is a robotic lobectomy in India, I think, where I'm using an assistant port. And I'll just talk you through inflammatory diseases and infective diseases. I think these are huge challenges. In India, we see all of these things. And addition to those problems, there is also this problem of nutritional depletion, paucity of expertise, availability of training, and things like that. So for me, when I do these operations for inflammatory disease, I strongly believe over the years now, with many cases under my belt, my recommendations are that the view that you get with VATS or on robotics is definitely 10 times better than open surgery. Because in open surgery, the illumination is not there. You're always struggling to get the light in. Whereas with VATS or with robotics, the view is 100 times better, and it is magnified. So everything comes under view. Every single addition gets taken out under vision. So the blood loss actually is less with VATS. In open surgery, you swipe your hands around and you do open dissection, and there's a lot more bleeding. With VATS or with robotics, we do not swipe. We burn every addition down. So every addition is dissected with energy. And so there is less bleeding than open surgery. And I definitely believe that the robot is an excellent tool at the thoracic outlet. And that's my take on it. In aspergilloma, in infected things, the ones that we've done are aspergillomas, bronchiectasis, lung abscess. I've even done a robotic and hydatid disease, and I've done pneumonectomies for destroyed lungs. Infected bronchogenesis, LVRS surgery in emphysema post-tuberculosis patients, post-TB residual giant bullous, pericardial window, partial pericardiectomy, which is a phrenic to phrenic pericardiectomy using the robot, cartilaginous syndrome with bronchiectasis, endobronchial inflammatory tumors or inflammatory myoblastic myeloproliferative tumors, any mediastinal lymphadenopathy with non-diagnosed masses, and hereditary disease. So inflammatory disease is a good indication. It's not a contraindication for minimally invasive surgery. That is the message I want to get across to you. From my series, I think inflammatory disease is a good indication for robotic surgery. Whenever I do aspergilloma surgery, I personally like to start voriconazole preoperatively at least 2 weeks, and I like to continue them postoperatively for 3 months. We have discussed this in the past, whether you need to do it or not. I feel comfortable with it. My pulmonologist feels comfortable with it. All the patients get medical optimization and usually try to complete HT if possible. The problem with the robotic, with the aspergilloma is that you always have these endobronchial connections. And if you don't take care of the rest of the lung and the rest of the lobes, you will have spillage. And that spillage will convert a localized aspergilloma into systemic fungal sepsis. So I've shown this before to you. My anesthetist usually in an aspergilloma does a lateral double lumen intubation. The patient's affected side is down. And once the affected side is down, then they will put in a Fogarty catheter into the disease side. So a simple explanation for this is if you're doing a right upper lobectomy, then the Fogarty's catheter is in the right bronchus intermedius, and the double lumen tube is in the left side. So essentially, you completely isolate the right upper lobe. So we aggressively follow these protocols when we are doing robotic surgery, because you have very little access for the anesthetist to the top. So we want everything isolated completely. And then we will always ensure that we check the Fogarty with fiber order. So this is the arrangement that you need to see. So in a right upper lobectomy, the Fogarty will block the bronchus intermedius. And so everything is isolated, only the upper lobe is exposed. But when you put a stapler across, you must remember to pull back the Fogartys. Otherwise, you'll accidentally staple the Fogarty. So be very, very careful when you do that. This is the video which I've shown before, I think. But I'll just show you how I do my aspergilloma surgeries. I just dissect enough to get into the chest. I don't dissect all the adhesions out. I leave the adhesions at the apex to pull the lobe, hold the lobe up. So the adhesions hold the lobe up, and then I get into the hilum very quickly. My aim in robotic inflammatory surgery is always to get into the hilum and start isolating the various structures. And for me, the most important structure in all of this is the bronchus. I want to get the bronchus as soon as possible. There is no particular order of dissection because there is so much inflammation. You have to decide whatever you can see, you go in and you try and take it away. Again, see, the beauty of the robot is it's allowing you to turn around and go behind the, this is the bronchus going up towards the chest wall because of the adhesions. And the robot is allowing me to dissect behind the bronchus. And that angle of the instrument is making it very easy for me to go across. I think this is being done in India. So my assistant is actually putting in the stapler, and he is doing what is called as a VATS lobectomy while I'm doing the robotic dissection. So he is at the patient's side. He is doing that. So we have got the structures that we need to get. I think the artery is the only one that is left. And I always use little sloops to go behind the artery because that gives me control over the artery and allows me to use traction. And so here we are now. We've got the arteries, we've got the vein, we've got the bronchus, and then all that is left is to take the dissection. But the dissection of the adhesions takes an extra 2 hours easily because there's a lot of neovascularization, lot of blood vessels coming from the chest wall. And see this, how clean the dissection is, because we are actually buzzing every single vessel. And you can use harmonic for this, and you can very nicely take every blood vessel and dissect the whole tumor out and take it out and deliver it out safely. So this for me is a very, very satisfying operation. And my personal choice is robotics in this. Again, something like this, a lot of people will say, you are crazy. Why the hell? Where can you get a camera into these patients? But my experience has been completely the opposite. when you have something like this with severe adhesions to the chest wall, I personally choose minimally invasive over open surgery because it gives me the difficulty is getting the first port in. Once you get the first port in, there's a technique to that. And once I get in with the first port, I will dissect as a uniportal and travel to the next port and make a second port and then travel to the third port. And once you've made the 2 or 3 ports and you've docked the arms, then all the dissection becomes very, very clear because it's all done under vision. It may take a little more time, but it's beautiful, clean dissection. And surprisingly, in all of these, very often you'll find that the hilum is spared. And if the hilum is spared, then it's all a matter of just putting your stapler across and stapling the artery, vein, and bronchus and getting the whole tissue out through your small ports. Again, we do sleeve resections and sleeve lobectomies, particularly for right main or left main bronchus. I'm a great fan of this. I will do a bronchotomy and transection when I am dealing with carcinoids. I remove the endobronchial tumor and I always send the margins for frozen section. And then we will do a bronchial anastomosis using the robot. And it's an excellent tool. So something like this. This is a sleeve resection, and sometimes you do a sleeve lobectomy. So it depends on whatever is needed for the patient. You'll end up doing that. So here is a patient with a inflammatory tumor in the left upper lobe, but the tumor is coming all the way down into the left main bronchus. And this guy had been advised a pneumonectomy. And I was not convinced that pneumonectomy is the right answer for this guy. So I told him that we will do this by robotics because the lower lobe looked fine to me. It looked as if the lower lobe was okay. The upper lobe had been destroyed. And so we went in by robotics. We found all these adhesions which we took down. Again, see, every dissection is taken down under vision. That's the message I want you to get. That there is no bleeding here. You see everything under dissection. And every little bit you take down and you keep sucking as you go along. Of course, it's not, blood-free surgery, but everything, we can see things clearly. Here I am taking the artery gradually. So I've not taken down all the adhesions. I've just opened up the fissure. And once I've opened up the fissure, I am taking the vessels as they come along. And I think this is in India. So we are using the laparoscopic staplers. We are nicely stapling everything out. And this guy was going to have a pneumonectomy by open technique. And we said, no, let's see if we can try and save it. So here we are. I think this is the bronchus that we're taking. We're dissecting it all out. No, it's a lymph node, sorry. So it's a calcified lymph node. So we've dissected the whole calcified lymph node off. And now the bronchus is free. We are clearing the bronchus to get a margin. So all the lymph nodes are being cleared out. My assistant is taking the specimens. And then I'm going around all these adhesions and stapling some of the vascular things. So I think this is the vein which I've taken probably. And once everything is clear, now the vision is excellent. I'm very happy with what I can see. I can see the left main pulmonary artery. I'm taking all the small branches at the back because I'm trying to do a sleeve resection. I don't want to compromise the lower lobe. So I'm trying my best to save the lower lobe. And here we are taking all the arteries to the upper lobe, dissecting it all out. All the dissection has been done. And remember, this is infective disease, okay? So this is all adhesions, serious adhesions all around. Even at the back, near the arch of the aorta, the bronchus is stuck to the arch of the aorta. But the vision is so good that you feel very comfortable to dissect at the back of the aorta, at the back of the bronchus. And now I'm going to make a cut on the bronchus because I want to get a clear margin if possible and do only a lobectomy. So here I'm opening the bronchus, again, protecting the inside. So, and the good thing is this instrument has got diathermy with it as well. So I've got a diathermy instrument with a scissor. So I can very nicely cut and buzz at the same time. And here I can see the tumor. The tumor is completely prolapsing into the lower lobe as well. So it is actually occupying the upper main and the lower lobe bronchus. And because I know this is not a malignant tumor, I can happily take it out piecemeal. If this was a malignant tumor, then I would not do this. But because this, we had a histology of an inflammatory tumor. So there is the tumor coming out. Again, everything is under 10x magnification. So you are seeing this only as a 2-dimensional view, but I am seeing it as a 3-dimensional 10x magnification. So every little blood vessel I can see, every little structure I can see, I'm nicely, making sure that everything is okay. I'll pass in a flexible bronchoscope. I'll suck out the remaining lung to make sure that there is nothing there, and I'll complete my bronchotomy at the back, and there is the whole specimen free. Now all I need is to take away the adhesions from the apex and deliver the specimen out. So now all I'm left with is this little stump, which is the upper lobe one, and then you take in the needle and you do suturing. And this is just like doing open surgery. I promise you, the beauty of suturing with the robot is second to none. And nowadays I've started using V-lock sutures. So V-lock sutures are sutures which you don't even have to tie a knot. You just pull it through and they stay. And you just put it through a lock and they lock itself. So you don't even have to tie a knot with the V-lock sutures. That's the beauty of the sutures. And so each one we're doing an interrupted repair, and we are making sure that the lower lobe bronchus is clear. Nice deep bites going in, sutures coming through smoothly. And again, see, this is like open surgery. This is how I would do it when I am doing an open surgery. So I'm nicely placing the suture along here. And nowadays, when I do a pneumonectomy, not in sleeves, when I do a pneumonectomy, I actually take the whole phrenic down along with the bronchovascular pedicle, and I put the phrenic on the bronchial stump. So that way I can cover the stump and also get elevation of the diaphragm. In this patient, of course, we are not going to do that because the lower lobe is still there. This is not a pneumonectomy. And so even though I'm next to the aorta and I'm in the aortopulmonary window deep down, I am able to suture. And then you just finish the surgery by taking down all the other adhesions at the end of the operation. So you don't take down these things at the start. They help you. They give you a good retraction. And then once you've done all of that, you just put it into a normal bag and take it out like an open surgery. So really, robotic is great when you're doing complex surgeries. I personally am a great fan of segmentectomies. I do unisegmentectomies, bisegmentectomies, multiple segmentectomies. In BARTS, we are doing a trial. My colleagues are actually using indocyanine green. So what they do is they inject the indocyanine green. And so the indocyanine green lights up the normal bronchus and tells you the normal segments. So it tells you where exactly is your staple line. They're doing it two techniques. One is intravenous indocyanine green, and the second one is endobronchial indocyanine green. So they do a bronchoscopy and inject the ICG and let it light up. So it gives you a clear definition of the margins of the segment so that you can put your stapler across it. This is a segmentectomy. I don't need to show you each one of these in detail. So that's so much so for lung surgery. Now, I also like to use the robotic for other surgeries. So I have used it for chest wall tumor resection. I use it for plication of diaphragms. I have quite a big series of ligation of thoracic duct using the robot. And I've done some cases of robotic pleurectomy in a case with ligation of thoracic duct. So it's like a combined pleurectomy plus this. So let me share this case with you of a patient with a second rib osteochondroma. Now this is a 16-year-old guy who is just who's just about to enter into naval school for the Indian Navy. And as he is getting into the naval school, he is sorry guys, can you see something is happening?
Widescreen only.
Yeah, 1 minute. I just did something by mistake. Okay, let me just stop this and restart it. Stop share. Sorry about that. It's me fiddling around actually. Is it making sense what I'm saying so far, or is it getting to be too long? I don't know what's happening. Okay, stop share. It's just I was fiddling with this. Okay, 1 minute. I'm going to just.
Don't ask leading questions.
Hmm?
Don't ask leading questions.
I can't hear you. What are you saying?
I said don't
Just 1 minute.
ask.
Let me just stop this and restart my PowerPoint. Sorry about that. This is my fault. I was playing around with the wires. That's fine. Let me just restart the thing from where I left off. Because this is a very, very heavy presentation. Oh, shit, something has gone wrong. Okay, 1 second. Okay, can you see now? Hello?
Yeah,
Sir,
we can see.
Able to see.
Are you able to see now? Okay. So this is a 16-year-old guy with who went into the naval school, and routine medical showed this tumor on the second rib. The problem is, to resect this tumor, you would have had to do a large thoracotomy, reflect up the whole scapula, and then dissect out the second rib and take out this tumor. He wouldn't pass his medical. Once you have a large thoracotomy on the chest wall, he wouldn't pass his medical. So what we decided is, we would go in the other way. We made tiny cuts on the chest wall and did not cut any muscle. And then we docked in a robot. And then, having docked in the robot, we then dissected the whole tissue of the chest wall. We could see it was a clean chest. So we could see the second rib very, very clearly. And we identified the second rib, and using a hook diathermy, I dissected the whole rib off with diathermy. And then the thing was, how do you cut the rib? At that stage, I did not have this instrument called a sophomore, which is a large endoscopic rib cutter. So what I did was, I took a giggly saw and I passed it through one of the ports, and I threaded it around the rib. And so once I had threaded the giggly saw around the rib, I brought it out through one of the ports, and I put in a syringe at the port to protect the port. I just protected the port so that there is no damage to the chest wall. And then my assistant just went to and fro and cut the rib using the giggly saw. And so once he had cut the rib, it just fell apart. So we did it on one side, and then we went in onto the other side. And then once we had cut the rib on the two sides, we managed to get the whole tumor out. So let me just speed this up. So this is the tumor. The whole tumor is coming out, and the robot is actually allowing me to dissect beyond the tumor. The bending of that thing, the ability to bend beyond the tumor, is pulling the whole tumor out of the chest wall. And we could very safely put it into a bag and deliver the whole tumor out. And this turned out to be a benign chondroma or something like that. Now, the important thing for me is that in this patient, this patient managed to rejoin the Indian Navy, passed his medical, and he rejoined the Indian Navy. And he met me a few years later when he was actually posted on a ship. So, thinking alternatively, we managed to save the career of this young child, of this young boy, and managed to contribute to the army. So it is really important to think different. Whenever you're faced with a problem, it's important to think different. Now look at how you can very easily suture the diaphragm. So I delivered the needle through the skin into the chest. So no port for the needle to come in. Look here, the needle is coming through the chest wall. And I'm very nicely and happily lifting the diaphragm and suturing the diaphragm. So it's really a piece of cake to do a diaphragmatic plication with the robot. It is so easy. It's just amazing how good a feel you get. And then you can do multiple layers of suturing and bring it all up. Of course, the only problem is you got to be very careful that you're not taking a deep bite, because that will then, you can take the stomach on the other side because you don't have a sense of feel. So that is something that you've got to be careful about. And then, you tie knots exactly as you would tie in an open surgery. And then you fix the knots. This is something I learned from the urologist, that you put in a liger clip at the end of your knots. So these knots will not slip. So watch that last knot, and I'm putting in a liger clip at the end of it to fix the knot into place. And so that way you can do multiple layers. So once you've done, so in this particular patient, I did probably a circular plication, but I do horizontal plications as well. It completely depends on what is the anatomy in the chest that is there at the moment. So it's really nice to do this operation, and it gives you excellent results. And you can do multiple levels and get a very nice tight diaphragm through this. This is a 26-year-old lady who presented with hydropneumothorax when she had a baby. So the history was two months history of delivery of a baby, and she developed right-sided effusion, and they put in a chest drain, and it turned out to be a chylothorax. The chylothorax was probably secondary due to a thrombus in the left IJV. So she had a left IJV thrombus, secondary to which the chylothorax was there bilateral and not resolving. And she was 2 months in a hospital, 8 weeks in a hospital with chest drains and unable to feed her baby. Her baby was, a young baby, and she was not able to feed the baby. So when the referral came to us, we said the best way is to just get into the chest on the right side, do a ligation of the thoracic duct on the right side, do a pleurectomy, and do a left-sided talc pleurodesis. And so this is what we did. We went in with the robot. The robot has to be docked the same way as you would do for any other surgery, except the orientation is the pelvic orientation, because now you're looking down rather than looking up. So you just have to split the orientation. And I do what is called as a mass ligation. So I also put in an NG tube and give what do you call it, cream through the NG about half an hour before I start scrubbing. So once the patient is induced and things, I give, and in the cream I put in some methylene blue. So methylene blue or gentian violet. So the methylene blue and the gentian violet lights up the thoracic duct, and you can see it clearly under vision. And then you go in and you dissect it out, and you apply liger clips, and you cut it off. I normally disconnect all my thoracic duct ligations. I try not to keep them connected. I just cut across it and disconnect it. And then you carry on and do a pleurectomy. So this is me using the robot to do a pleurectomy and completely dissect the pleura out on that side. Probably done an apical pleurectomy and a left-sided this thing. And really within 3 or 4 days, this patient got discharged. The lung re-expanded. There was no more collection of chyle. She was started on anticoagulation for the IJV thrombus. And within 4 days, she went back to her baby. So again, thinking differently helps you with these things. Now, robotic surgery is not without its complications. I showed you one case of intraoperative bleeding. When it happens, it can happen really, really seriously. And undocking the robot is a protocol that you must practice. And I will share the protocol with you guys to what is the protocol for undocking a robot. I haven't put it in these slides. I had one case which is really interesting. Whenever we do robotics, at Medanta, when we do robotics, we use the insufflators. And the insufflators are usually GI insufflators, the laparoscopy insufflators for CO2. Now, what I did not know at the time was that these insufflators have a default setting of 16 to 20 liters flow. When I do thoracic surgery and when I put in CO2 into the chest, I will flow the CO2 only at a rate of 6 liters, 4 to 6 liters, and a pressure of 4 to 6 liters, because I don't want a tension pneumothorax. So I am very aggressive with putting the flow down and the pressure down. What happened in this case was that the electricity in the whole building went off and restarted onto generator. So it was a split-second change of the power supply. We have a UPS, uninterrupted power supply, but that split-second switchover from central electricity to the UPS caused the insufflator to go back to default setting. And I just continued operating, not realizing that the insufflator was blowing CO2 at the rate of 16 liters per minute. And suddenly the blood pressure started to fall. The patient, the anesthetist looked up and said, everything was going smoothly. We were doing, I think, a thymectomy. And everything was going smoothly. And suddenly the anesthetist said, patient arresting. Something is wrong. Just look at it. So the first thing I realized what was happening. Luckily, I realized what was happening. And I asked the assistant to open the ports. And the moment he opened the ports and let go all of the CO2, we got some sort of control. And then I quickly scrubbed in. And by the time we could solve it, the patient had dipped quite dramatically. So I just opened the chest. I made a small mini thoracotomy and released everything out. And the moment we released out, we realized that this was a tension pneumothorax secondary to default setting on a CO2 insufflator. And so the ability to undock the robot was very, very important to save the patient's life in this situation. So it's very, very, very important to understand. And then we had a few cases where the arms were not properly placed, or the robot was not, the ports were not properly placed. And as a result of excessive movement of the arms, we ended up bruising the arm or the chest wall. And these things have been reported in literature. So we've had to convert for bleeding, for tension pneumothorax, and bruising of the arms. This loss of power thing is a very interesting case where we had, what happened was, we were doing, I again think it must be a thymectomy. I don't remember what it was. And we had docked the robot in the patient. We just put in the robot, and suddenly the entire power in the theater went off. There was some major short circuit, and the entire theater became black. And the robot, when the power goes off, it freezes. So the anesthetist, even the ventilator went off. So what the anesthetist did was she took over from the ventilator to hand pumping. So she was hand pumping. A second guy was holding a light, a torch, a big torch. We didn't know what the hell was going on. And the robot had frozen into the patient. But luckily, I was not holding any organ inside the chest. I had just docked it in. So arms were in the chest, but frozen. So you cannot undock the arms. The arms had frozen inside the chest. So what we did was we took the bed down. So we left everything as it is, and using the hand-operated crank, we pulled the patient out of the robot rather than the robot out of the patient. And having pulled the patient out of the robot, hand ventilating the patient, we put it on a trolley and went to the next theater, which was working, thank God. And then we set up everything by VATS, and we finished the case by VATS. So funny things happen, and you got to think on the spot, and you have to save the patient's life, because here, if the robot is frozen, there is no other way to do it, to get the patient off the robot. So we had to pull the patient down. So what is next with robotic thoracic surgery? I think uniportal robot is already here. The SP robot, a single port robot, is being tested. It has been used very well in abdomen. It works very well with the abdomen. The problem with the chest is that it is still a large size. The diameter of the SP robot is still a large size. So this diameter still cannot accommodate the intercostal space. So that is the struggle that we have with the uniportal SP robot. So until and unless they reduce the diameter of all these instruments, it's going to be slightly difficult for SP to become a very popular tool in robotic surgery. So I do two types of uniportal robotic surgery. One is sub-xiphoid thymectomy, where you air dog the robot. So you make a single incision and all the ports going through the same hole. So it is called as air docking through a single port. So your ports are outside. Your instrument just enter in through the single incision on the chest wall. We've also done a first rib resection through the axillary approach by air docking through a single. So we made an incision in the axilla and dissected across the chest wall into the top of the chest wall, and the robot was outside. The instruments were just going through the incision, and we were lifting it up in the air. And we tried to do the first rib resection. Now, there are new robots coming in, which are called as hybrid robots. These are newer designs, which may hit the market in some time. These are compatible with laparoscopic instruments. So using a robotic platform, you can use some of your laparoscopic instruments on these things. And they're also compatible with the routine staplers that you're using. And these designs are still on the table. Now, I cannot show you any of these pictures because I have signed non-disclosures with all these companies. I'm involved with a lot of development of these instruments, but because this is all very secretive and very sensitive, I'm not allowed to show any pictures in any presentation, at least not as yet. So these are all things that we're doing. Fluorescence robotic surgery is here. Fluorescence robotic surgery is using the ICG. So you give an injection of ICG and then you use a laser light. And when you use a laser light, the laser light lights up the blood supply. So it works very well for something like the esophagus, where if you want to dissect the esophageal, the gastric tube, using the ICG, you can very easily highlight the vascularity of the stomach. You can also use it for segmentectomies, where you highlight the vascularity of the segment, or you can use it to highlight the tumor. So this is where we are doing a nodular resection of the tumor, and the tumor is highlighted by the ICG as opposed to the rest of the lung. And so this is a technology that you can use. This technology was always designed to be Wi-Fi. It was designed, the original idea of doing robotic surgery was by NASA for space. So when their astronauts went to space, and if they had say acute appendicitis, you would not have the time to bring the astronaut down to Earth. So sitting down in Chicago or in Houston, wherever their center is, they could actually control the robot in space to do the surgery. So this is the really intercity or international robotic surgery is there. It's already been done. The patient was on the east coast of US. The surgeon was on the west coast. In Europe, the patient was in Germany. The surgeon was in Switzerland. So all of this is always designed for wireless technology. But what you need is something called as Internet 2. Most of you may not even be aware of the existence of Internet 2. Internet 2 is a broadband, is an internet system which is used by the military. Okay, this is not your standard internet that is available. All wireless robotic surgery works on the Internet 2 platform, which is 56,000 times faster than the current internet. So most of the military use these internet. I mean, you might be aware that internet started as a military technology. It's called as DARPA, D-A-R-P-A. And that was the first technology from which internet originated. But the governments of the world have something called as Internet 2, which is 56,000 times faster. And whenever we have to do a wireless transatlantic or trans-city robotic surgery, we have to get access to Internet 2 so that all your images are transferred in real time. You cannot have a time lag when you're doing an international wireless robotic surgery. So the reality is that this technology has left the station. Okay, no longer are we asking you, whether do we need to do it or do we not need to do it. This train has left the station. We are already there. It's going to go. is going to go with you or without you. That's the day. We are no longer, we don't need you. The question is, do you need us? Do you choose to be on it or do you choose to be left behind? I no longer do presentations where I have to convince the people that robotic surgery should be done. There are many, many, many skeptics and we don't worry about them. We just ignore them. We ignore the skeptics and we just get on with life and we do what we have to do. I've shown you these images before, but I'm again put it into the robotic platform. It's very important. When you want to fly high like an eagle, when you want to achieve success at the highest level, it is absolutely mandatory to not hang around with the turkeys. There are people around the world who will tell you every single reason why you cannot succeed. They are your neighbors, your boss, your next hospital guy. There are hundreds of people who will discourage you at every stage of life. When you want to succeed, all these people will tell you every single reason why you cannot succeed. But you must choose to fly high. You have to just change your friends, run away from people who talk rubbish about these things. When I came from the UK, I had a very comfortable life in the UK. I was, Monday to Friday working, Saturday, Sunday off, living in a really nice house. There was a spa in the house. There was everything. It was all comfortable. But I chose to come to India because I thought it will be a great journey. And really that one decision of moving from UK to India changed my life completely. And that decision to make the journey on a path less traveled is what made all the difference. So most people go from India abroad to get fame and success. I must be the only guy who came from abroad to India to get fame and success. So for me, really the reverse migration worked very well to get my hands onto the robotic technology. And I owe everything to India. I owe it to India for giving me this technology, for giving me access. And Dr. Naresh Trehan, who was a visionary, who is a visionary. And I was lucky to actually get on the same platform as him. And that one single decision made a whole difference. So, there are enough people around who will say that you cannot do this. But the ones who change the world, they are the ones who are crazy enough to think that they can change the world are usually the ones who do change the world. So it's an 80-20, Pareto's phenomenon. It's called as Pareto's theorem. 80 people of the world do nothing, but they say you cannot do anything. And 20% of the people who do everything are the ones who say they do everything. So it's an 80-20 philosophy in life. So you can choose to be either the 20 or you can choose to be the 80. It doesn't matter. My life is my life. I'm very happy with it. You are the young guys. You are the ones who have to choose whether you want to change your methodology or not. At the end of the day, I said right at the start of my talk that robotics is just a tool. It is a tool that you have in your armamentarium and you choose selectively what works for what patients. Whether you want to do multi-port VATS, uniport VATS, robotics, single-port robotics, whatever you want to do, choose your tool carefully. But important is do not compromise the surgery. You cannot compromise the quality of the surgery for the access. And that is the message I want you to take home with you at the end of this talk. Thank you.
Thank you, Zamir. It's an excellent as usual.
Thank you, Sri Krishna.
I just have one question.
Okay, I'm just going to increase the volume, Sri Krishna. 1 second, I had lowered my volume because of the sound. Yeah, tell me.
Have you ever used, I think it's called FlexTech or something,
Yeah, I have.
Endorist technology for VATS?
Yeah, FlexTech. See, one of the problems with robotics is that it is a big platform. It's very cumbersome. To dock a robot is extremely cumbersome. So there is a new technology which has come in, which is called as FlexTech technology, which is handheld robots. So I don't know why that slide was not there in this talk. Maybe I picked up a different talk, but it is there in my talks. In some talk, I have definitely spoken about FlexTech. So these are handheld robots. So you hold it in your hand, you go onto the bedside of the patient, you operate, but the movements you get are exactly like with a robot. So it's a new technology. It's nice, but obviously the vision is not the same. You see, the camera is not robotic. The FlexTech is robotic. So
Yeah, true.
the,
No,
the
the
vision
thing
is not
was
there,
that,
but the movement is there with FlexTech. So it is good. It's good.
okay. It's use of endo wrist in VATS setting.
Absolutely correct. Absolutely correct. It's a robotic platform in VATS setting. It's a hybrid technology. But the vision is still VATS.
Correct. Correct.
Okay. Who else wants to come on? There
But,
was some
but then your tactile sensation will be better.
maintained. Yeah. The tactile sensation is maintained with FlexTech. There are a lot of, I don't know why I didn't look through the whole talk, but I haven't spoken about endoscopic robots. I have a huge talk on endoscopic robots. Probably it is there in one of my other talks. So we do endo-oral robots and endobronchial lobectomies and things like that. All that is still there. Those are all new technologies which are being developed. I'm involved with some of them in developing the endo-oral robots.
Okay, thank you very much.
Thanks very much, Sri Krishna. You stayed up very late.
Yeah. Nice, nice.
Okay, thank you. Thank you. Anybody wants to ask? Vikas, you're there. Now, can you just take these questions? I don't know what's happening. What are these questions?
Sir. May I ask asking, sir, when do you remove drain if you have done extensive mediastinal node dissection for lung or esophageal carcinoma robotically?
Day one.
Concept still same, or do we wait a little longer?
No, day one. Day one. You have to read the Copenhagen experience, okay? Please go online. It's in European Journal of Cardiothoracic Surgery. The Copenhagen experience from, I forget the name of the guy.
Rene Patterson. Rene Patterson.
No, it's not Peterson's paper. It's somebody else's paper. I'll get you the paper. It is there in my collection. I'll send it to you. Amount of fluid that comes out makes no difference to removal of the drain. That's the most important message. So they take out at 600, 700. I have a cutoff of 300, 400. But fluid no longer matters to me. I take out the drains. The presence of a drain acts as a foreign material and inculcates fluid to be formed or inflammation to happen. So I don't, it makes no difference. If I've done it, only infective cases, I will leave it longer. Whenever there is infection, I leave it longer. Otherwise, I just take the drain. In clean surgery, there is no indication for leaving it longer. Yeah, Vikas, come on.
Next question is, in esophageal malignancies, do you keep the drain till you do a contrast study or you remove it?
Yes. In esophagus, you usually keep it till the contrast. Day 5 or day 6. I was trained by Joe Rahman and David Whedon in esophageal surgery, and so that is the principle that we still follow. But now I don't do much esophagus because when I came to Medanta, Dr. Chowdhury was already well established in esophageal surgery. So I never treaded on his foot. I didn't want to create any bad feelings. So I almost stayed away from esophagus. But in my own practice for benign esophagus, I still do a lot of benign esophagus, but malignancies of esophagus has almost gone to upper GI now.
Okay, thank you, sir. Sir, another small question I have. This is Dr. Priya here. On what day do you do a contrast study routinely after your esophageal malignancy?
Day 5.
Day 5. Okay, fine. Great. Thank you, sir.
Next question is, during port placement, do we follow 9 centimeter rule or modify according to BMI or local topography?
No, usually for the SI, in a standard patient, you follow 9 centimeter rule. In an XI, you don't follow the 9 centimeter rule. You reduce that to 7 centimeters. And in a fat patient, you can increase, because the problem with Indian patients is it's a very narrow chest. And to put in 4 port, there is not enough space. You calculate 9 by 9 across from the sternal edge to the back of the vertebra. There is 32 centimeters are not there. Whatever 9 ports are is what, 36 centimeters. You don't get that distance. And the lateral 3 centimeters next to the vertebral column, you don't want to put in a port because that is a very narrow space. So that is called as a no-fly zone. So you have to leave 3 centimeters next to the vertebral column. So there's not enough space in an Indian chest. But if it's a fat person, you have more space. So you can then increase your distance. Better in an SI, more the distance better. In an XI, it doesn't matter. XI is very accommodative. It's a slimmer profile, so the clashing does not happen. The reason why you keep this 9 centimeter is because you don't want the arms to clash. Once it starts to clash, it's very, very troublesome to operate. Yeah. Okay. Yeah, Bhushan, you were saying something?
Here, Dr. Surendra Patel here, sir.
Hi,
I want to ask one question, sir. I am doing open thoracic surgery, all types of, and I want to just start robotic. And I am at All India Institute of Medical Science, assistant professor in Jodhpur, and we have a robotic system, but our urology colleague and GI surgery colleagues are doing. How can I start there, sir? Can I have to take some training sessions, and from where I can get to train, sir?
Okay, so the legal requirement now with Intuitive, the legal requirement is that there are 3 levels of training that you have to do.
Okay.
First is training for the instruments, training for the doc. It's called as console time training. That console time training can be done on your console. Every console that you have in a hospital has modules for training. Okay. So the first 20 hours or 25 hours you have to do on the console in your hospital, and that training can be done in the evenings or on a weekend on your local hospital. You have to get permission from whoever is your robotic director. Okay. The second is basic level training with Intuitive. So you need to get an Intuitive certification for using the robot. And that, I believe, in India used to be in Kochi. I think that's moved now. I'm not sure where it is now, but if you contact your Intuitive representative, they will do that for you. Now, there are 2 or 3 ways that coaching is done. It costs money. It costs about 1 to 1.5 lakhs, I think, if I'm not mistaken. Okay. But whenever Intuitive installs a robot, it always gives certain free slots for the hospital. So if your hospital has got any of those slots available, then use them. If they haven't got the slot available, then you'll have to pay for it, or you will have to get some company to sponsor you. So that's the second. And then the third one is all advanced training. So you have to do, you have to visit, you cannot start your program straight away. Once you've done the robotic certification with Intuitive, then Intuitive will appoint a preceptor for you. It's called as a preceptor model, where the preceptor will come to you and he will sit with you while you're doing your first case. And there are a certain number of hours that you have to do with the preceptor on site. And then the preceptor has to assess you and sign you off, because there's a medical legal issue with this. So companies are now getting more and more careful about who sits on the robot. Because if you're not trained and you create an accidental injury, then the company gets a bad name. That's why they are becoming very strict about this. When I started doing robotics, there was no training and there was no center which was doing this. So we learned on the robot and we got local certifications on the robot. We did hours on the robot. But now it is very, very strict. The medical legal situation is very strict. So you have to go through the Intuitive platform. Speak to your Intuitive rep. He will guide you through the whole platform. It does cost money. It does cost money.
So,
it's important.
For the second step, there is huge criteria, sir. They don't accept any person, even for the second step. You have to show that you are doing monthly, at least minimum 20 to 30 cases of only lobectomies is what their criteria is. This is the Intuitive criteria.
Whatever it is, I don't know what it
is. I mean, even the second step is not very easy because I've actually cleared the first step.
It's not that it's not very easy. It is actually doable. Everybody, all my juniors have done it, and my registrars are all going on to the in UK. My registrars are going on to the course, and it's not difficult. I promise you, it's not difficult. And
no, maybe
it's not that you have to 20,
30.
It's not that you have to do 20, 30 cases or whatever. I don't think that is correct, because the whole idea is to encourage people to do robotic surgery. But you have to start doing it stepwise. Small fish first, intermediate fish next, and large fish after that. So I don't think that is our registrars.
I'm just telling about the India experience. That's it.
Even in India, actually, I am in the process of putting some people through robotic training, And I don't think that is the criteria. The point is you cannot do 30 lobectomies and then go for training.
Exactly. It's very
The
difficult.
bottom line is no. So that is incorrect. What you're saying is incorrect. I don't think that is the criteria. The criteria is that you need to have done all these things before, and then you can do a lobectomy. So that is not the criteria. I'm pretty certain about it. My registrars here have done it, and in India we are trying to send some people for training. So I don't think that's the criteria.
Okay, and that is good actually. It's a good news.
Yeah. Who's next? Any other questions?
No questions on the chat, sir.
Okay, all right, good. So we are doing well. What's the time? 7:30. Not bad. Let me stop recording. Okay, so that's it. Did it make sense?
Yes, sir. Definitely, sir.
We had a very poor attendance today, actually, surprisingly. I thought
we started with some 34 people.
Yeah, I'm surprised because I thought robotic people would want to listen to, but that's okay. I don't know what's happening on the other platforms, but I'm sure they must be. Let me just stop the YouTube.
Sir,